Welcome to AETCM, the emergency medicine channel. Today we are going to discuss a case of diarrhea in children. Shall we start?
Yeah.
A 2-year-old child presents to the ER with multiple episodes of loose stools of 1-day duration. On our initial PAT assessment, the appearance was irritable, the breathing was normal, the color was pale.
Okay. So just we'll hold on. So a 2-year-old child, appearance, the child was irritable. Breathing normal, color was pale. So what is your initial impression?
Initial impressions are the child is looking stable, except that the appearance is mild irritable. Otherwise, child is
Pale?
pale, but still it is not motile or no cyanosis, no other things.
Okay. So the child is irritable. So with this background and with the history of diarrhea, loose stool of 1-day duration, what you have to anticipate, there is some problem in the circulation.
Yes,
so there doesn't look like any problem with breathing. So there is some problem with circulation. That is the only thing that we can come to know from this assessment. Okay.
Coming to the primary survey, the airway was patent, no pooling of secretions, no gurgling.
Okay.
Coming to breathing, respiratory rate of 28 and saturation of 98% in room air. Air entry bilateral equal, no accessory muscles for respiration. Coming to circulation, the heart rate was 104 and BP of 90/60 millimeters of mercury.
Can you just tell me the normal heart rate, BP for this age?
Sir, our child is having an age of 2. So up to 12 to 18 years, 18 months, the heart rate is 80 to 20 and
80 to 120.
120.
Okay.
And BP is calculated by systolic is 90 plus age into 2. If it is hypotension,
plus age into 2.
2.
So what is the anticipated this thing? 70 plus age into 2. The child is 2-year-old. So systolic BP can be 74. So this is the 50th percentile. This is not the normal. This is the 50th percentile. Above this is the minimum requirement. If it is below this, it is below the 50th percentile, and you can straight away say that the child is in hypotension. So what are the different types of shock that you can have in a child? So this child is not in a shock. So what are the different types of shock that you can anticipate in a pediatric age group?
So most commonly it is hypovolemic shock.
Okay. In dehydration we are dealing with hypovolemic shock. What are different types of hypovolemic shock that you can think of? So here you say the CRT is less than 2 seconds and there is no hypotension. Suppose I am saying that CRT is 4 seconds and there is no hypotension. So what type of shock we are dealing with? So whether it is compensated. This is compensated shock. So what we can say is that this is a compensated shock. Suppose CRT is elevated, that means there is some issue with the perfusion, but there is no hypotension. That means this is a compensated shock. Suppose there is hypotension also, what is that? It is decompensated shock. So we have to differentiate whether it is a compensated or a decompensated. In a child, we have a normal compensatory mechanism by which the body will try to compensate the hypotension. So the patient will not go into hypotension till like 40% of body fluid is lost from the body will try to maintain the body perfusion and also the hypotension. So below, if the blood loss is or the volume loss is above 40%, the child will go into compensation and the child has gone into decompensated shock. So and hypotension. Okay. Fine. Continue.
Disability, the patient responds to verbal stimulus. Pupil 2 mm equally reacting to light.
Okay.
Exposure wise temperatures 98.2 degree Fahrenheit and GRBS of 78.
Okay, fine.
Coming to sample history, there was no allergic history, no drug history, no history of similar episodes in the past.
Okay.
The last meal was taken 2 hours back. Antenatal history was uneventful. Postnatal history was uneventful. Immunization history, immunized up to age.
Okay.
According to the National Immunization Schedule, the latest guidelines is that 16 to 24 months, the doses has to be taken as measles and rubella second dose, OPV booster, DPT booster, and also Japanese encephalitis second dose.
Okay. Immunized up to age, you said. So I just wanted to know, any immunization has been done recently within 2-3 days
no,
for this child? That is again very important. Why you want to know that history? Post-vaccination fever, post-vaccination they can have diarrhea, and all those it can be attributable to the vaccination whatever the child has received. So that history is important. If you are saying immunized up to the age, that is also not relevant. But any immunization that has been done frequently also you need to say it. Okay.
Then coming to events, a 2-year-old child presents to the ER with complaints of 4 to 6 episodes of loose stools, watery in nature. There was no history of any fever, blood in stools, abdominal pain, decreased urine output, vomiting, constipation, trauma, or any drug intake.
Okay.
There was history of food intake from outside.
Okay. Fine.
Coming to head to toe examination, the anterior fontanelle was fused. There was sunken eyes.
Okay.
Tears were present. Oral mucosa was wet. Skin tiger or skin pinch time slow, less than 2 seconds.
Okay, CRT was already normal. So sunken eyes, what does that implicate? That is only one positive finding that you have in here. So sunken eyes, what does that mean?
It indicates that the patient is in dehydration.
What type of dehydration?
Some dehydration.
Some dehydration. It is very some dehydration. We will come to the discussion. So we have a 2-year-old child who has been brought to the ED with multiple episodes of loose stools. There is no history of fever. There is no history of fever, just loose stools. There is no history of vomiting, and child is tolerating oral feeds. So that is very important. If the child is having vomiting and diarrhea, then you are in a difficult situation. But here the child doesn't have got any vomiting. The child is tolerating oral feeds, and the child has no hypotension. CRT is normal, and you have evidence of some dehydration. That's the only thing. Okay, fine.
Coming to vitals,
we have already said.
Systemic examination, GIT, it was soft, non-tender and bowel sounds present.
Okay.
Other systems was within
normal limits. Okay.
Coming to diagnosis, it was acute diarrheal disease with some dehydration.
So it's an acute diarrheal disease. So when was that food intake? It was within 1 day, 2 days, or 3 days?
Within 2 days, sir.
Within 2 days. So what would be the probable causative organism?
So it can be most common cause of diarrhea in children is rotaviral infection.
Viral infection, among that rotavirus, but usually now the children are getting vaccinated for rotavirus. So there are other viruses also which can present similarly, and even COVID they can present with acute diarrheal disease. So any viral infection they can have. So usually what we will see is a viral diarrhea, viral infection relating to an acute diarrheal disease. Also we can have bacterial, but here it doesn't look like a bacterial infection, more in favor of an acute viral diarrhea. That is the main reason, with some dehydration. That is very important, with some dehydration, because the child only had a sunken eyes. There was no other evidence of dehydration. Okay, fine.
Then coming to the management part.
Okay. These are the, you can just show that slides, people will come to know. This is the pediatric vital. See, as I always say, whenever you are getting a child, you need to know what is a normal physiological parameters for that age group. Then only you will know what is abnormal for the child. So 1-year-old child will have different vitals that of a 2-year-old. A newborn will have a different vital that of a 1-year-old. So all these age groups you should know the basic vitals. So you cannot remember everything. So something like this chart you can keep it with you so that you can go and refer.
Then coming to looking at head to toe signs of dehydration.
Yes.
You have to look at the anterior fontanelle.
So when the AF usually fuses?
12 months.
12 months. So it's a 2-year-old child. So it's a less than 1-year-old child, or 1.5 years. Till that you can take that. So sunken anterior fontanelle is one of the signs.
Sunken eyes.
Yes.
Less or no tears has to be checked.
Yes.
The oral mucosa has to be checked.
Yes.
Skin tiger. It's also called skin spin time. There is some
skin spin time. Basically, you pinch the skin and see the turgor elasticity. The child is dehydrated, the skin turgor is going to be prolonged.
Actually, in the skin tiger, it is also called the skin pinch time.
Okay.
Usually, it can be referred as normal and slow and very slow.
Okay.
Normal means usually less than 1 second. Slow means less than 2 seconds, and very slow means more than 2 seconds.
Okay.
Then increased capillary refilling time and cold, cyanotic or motile extremities.
Okay. So here the child only had a sunken eye. That's fine. You can go ahead. So now we have a child who have got some dehydration, who is able to tolerate oral feeds. So what is the treatment? It is pretty simple. What is the treatment? You have to give oral rehydration solution. You have to rehydrate the child orally. The child is able to, so this is the WHO composition, and also you can make homemade ORS. So can you just elaborate on it?
So in this case we will give WHO ORS, which contains mainly glucose.
You need to give energy to the child. We need to give electrolytes to the child. That is our idea. So it's the ORS, whatever you are giving, it should have electrolytes and energy. So there is glucose, sodium chloride, trisodium citrate, and potassium chloride. That is which is mandatorily required. And there is another one which has got lower osmolarity, which will have contained lesser amount of salt. That's only basic difference. Only the sodium chloride will come down and the sugar also will come down. Only maybe irritability or all those things you can maybe sometimes you can give low osmolarity ORS. Okay.
These are the signs of dehydration, which pictorial representation.
Sunken fontanelle, sunken eyes, lack of tears when crying, want to drink a lot of water but may vomit. In a 6-month-old child, you can ask how many nappies you have changed. So that is a sign that if the child is severely dehydrated, the urine output will significantly come down. That is the one thing that you can do. Okay. Then rapid breathing, increased heart rate, restlessness, lethargy, weakness. Okay.
Then coming to
classification of dehydration. Yes.
Initially, we classify dehydration like no dehydration,
yes,
some dehydration, and severe dehydration.
There is no dehydration here. There is some dehydration. Severe dehydration. Yes.
Basically, in the ES department, we have to identify no dehydration, some dehydration, severe dehydration. In the history itself, we can get if the child is alert, it is no dehydration. If the child is irritable and thirsty, it is pointing towards some dehydration. And if the child is lethargic, it points towards a severe dehydration. And second comes on our examination, the skin pinch time, as I told you.
As we already discussed.
And once we come to the diagnosis, our treatment plans depends upon this no dehydration, some dehydration, and severe dehydration. No dehydration, we go with plan A, some dehydration plan B, and severe dehydration plan C.
We will go plan C. And also nutrition zinc supplement that we can give for all the child with acute diarrheal disease. That is, there has been some evidence on giving zinc, and there is an improvement in the total episodes, and the duration of the diarrhea has come down. So we can try definitely zinc supplements. Okay.
Coming to some dehydration, initial no dehydration, our plan is plan A.
Plan A.
In plan A, we aim at replacing the ongoing loss.
Yes.
That also categorized as less than 6 months. We will give 50 ml ORS for every episodes of loose stools. And 6 months to 2 years, we will go with 100 ml ORS for every episodes of loose stools. And more than 2 years, we will go with 200 ml of ORS for every single episodes of loose stools.
This is the additional fluid that is required. See, genuinely you require fluid. You need to replace that fluid. The child is able to take that, that is well and good. This is the additional replacement that you need to give after each episode.
That is plan A with no dehydration.
Okay.
Then we come to plan B where there is some dehydration.
Yes.
This is basically categorized into 3 headings. One, you have to correct the dehydration.
Dehydration.
Then you have to go replacement of the ongoing loss. And finally, maintenance fluid for the child.
See, why in plan A there is no these things, that there is no evidence of dehydration. That is only why we are giving just the whatever loss is there we are giving. Here, as I told before, you have to correct the existing dehydration. Then you have to replace the fluid and you have to give a maintenance fluid. Okay.
Coming to dehydration of the child, in plan B also, we stick with other child is taking oral feeds, we go with ORS. That also 75 ml per kg ORS over 4 hours.
Okay.
That is plan B management for correcting the dehydration. Then we correct the replacement loss. That is same as plan A. Then we come to the maintenance therapy.
That you can go with holiday Segas formula.
That is for 24 hours maintenance fluid. For initial 0 to 10 kg, we will go with 100 ml
per kg.
And then 10 to 20 kg, we go with additional 50
ml per kg.
And more than 20, we will go with 20 ml
per kg. Just 0. It's not coming. More than 20 ml. Okay.
20 ml per kg.
Okay.
That is management of some dehydration.
Okay.
Then we come to severe dehydration. We will go with plan C. The major difference between plan C and plan B is we will correct the dehydration, but in plan C, since the child is lethargic, we will go with IV fluids,
correction,
preferably ringer lactate, as it contains more electrolytes.
It's more balanced fluid. So we'll go for a balanced crystalloid. You can name it as a balanced crystalloid, but here the problem is that energy is not being given. Only electrolyte correction and fluid correction will happen. So energy collection, you need to think either a half DNS or you need to give something else.
That is ringer lactate IV fluid is preferred. That is for correction of dehydration. Then we come to replacement. Replacement is same and
maintenance also is the same. Only thing is that you have to correct the hypotension.
The ringer lactate IV fluids it is given at a dose of 100 ml per kg. And that for less than 1 year old child the correction is given in 6 hours.
6 hours.
And more than 1 year old child the correction is given in
3 hours time. So in a lesser age group we will go a little bit slowly, and in older children we can go a little bit faster. There is hypotension, you go with the standard formula of 20 ml per kg correction. You can give multiple boluses. If some dehydration, if severe dehydration has taken the child to hypotension. So severe dehydration, the child might be lethargic, but the child might not have gone into hypotension. If there is associated hypotension, you have to go with 20 ml per kg rule to correct that hypotension also. Okay.
Then other parts of management is you have to look for the nutrition. Then SING less than 6 months you will go with 10 mg per kg,
10 mg.
And more than 6 months you will go with 20 mg per kg.
20 mg.
SING helps in the epithelialization of the intestine and decreases the frequency
of diarrhea. Okay.
Then
see, my question is whether we need antibiotics. Indications for antibiotics, that is other question. See, everybody, parents, they might demand why the doctor is not, he's just giving to tell you ORS, why no antibiotics was given to the child. But that is again one important thing, no need of any IV antibiotics for an acute viral infection unless and until the child is having a persistent fever, there is a blood tinged diarrhea, and you have any other evidence of a bacterial infection, only there is a need of an IV antibiotics or an oral antibiotics. Because antibiotic itself will kill the normal flora and they can have antibiotic induced diarrhea. So if needed only, you need to put the child on antibiotics. Okay.
This is as we discussed the plan.
Whatever we have discussed.
Treatment diarrhea at home, the extra fluids.
Okay.
Plan B.
Treatment, some dehydration.
Treatment of plan C.
Plan C. Okay.
Then we come to the most common causes. Viral is the most common cause. Rotavirus, other viruses like adenovirus, norovirus, and sir, you told
COVID also, because that was the most frequent presentation in children.
Then bacteria like Salmonella, Shigella, Vibrio, E. coli, protozoal and fungal. Fungal is most commonly seen in immunosuppressed patients. Then persistent or recurrent
very important thing that you have said. Lactose intolerance, malabsorption, food allergy and celiac disease. See, food allergy is one of the most common thing that we need to have a suspicion. The child is not having any fever, a recurrent episode of diarrhea. Why? Maybe it's just a food allergy and you need to avoid that food material. Okay. Okay. So, what we have discussed here is an management of an acute diarrheal disease. So, it is pretty simple and straightforward management. What we need to remember, that you are able to give oral feeds, that is more than enough. So correct according to the evidence of dehydration. No dehydration, you just need to supplement after each episode of loose stools. Some dehydration, you need to correct the dehydration as well as you need to supplement it at the time of diarrhea. And severe dehydration we have to cover, and also maintenance fluid. And in severe dehydration you have to correct, if there is hypotension, then you have to give maintenance fluid as well as you have to give the replacement for each episode of diarrhea. So routinely there is no indication for antibiotic, just oral is enough, and there is no indication for an IV unless and until the child is not able to take orally. The child is able to take orally, that is well and good. So simple ORS, oral rehydration solution, which we can make homemade ORS also. Can you tell me how will you do an homemade ORS? You can 1 tablespoon of sugar you can add and 1 pinch of salt you can add to it, and to a 1 liter parboiled water, and you can make an homemade ORS also, which we learned in community medicine. So that's a pretty simple thing, so that you can remember. So if commercially preparation is available, you can give that. Otherwise you can go with homemade ORS also. Okay, thank you. Good.